Hi there, my name is Joan and I am an instructor with the ACCN program. This presentation is part 1 of 4 discussing medications for Module 5. In this first presentation we will focus on catecholamines. If you have not already done so, please ensure you have reviewed the presentation on adrenergic receptor activation definitions, autonomic nervous system and adrenergic receptors, and the determinants of cardiac output. As you will recall from the review PowerPoint, catecholamines exert their effect via adrenergic receptors. These receptors are subject to downregulation, desensitization, and upregulation, which can affect the response to the medication. Therefore, except for a few exceptions, we generally titrate these medications to hemodynamic effect. For example, norepinephrine stimulates alpha-1 receptors causing vasoconstriction and increasing blood pressure. So a common order would be for norepinephrine to titrate to maintain a MAP of greater than 65 millimeters of mercury. Epinephrine is a direct-acting, non-selective adrenergic agonist, meaning it stimulates alpha, beta-1, and beta-2 equally. It is, however, dose-dependent. At low doses, the primary effect is an increase in heart rate, AV node conduction, and contractility via beta-1 receptor stimulation, and vasodilation via beta-2 receptor stimulation. At higher doses, alpha-1 receptor stimulation increases, and beta-2 stimulation decreases, causing vasoconstriction along with the existing beta-1 effects. So epinephrine has both vasopressor and inotropic effects, which makes it a useful drug in treating many life-threatening situations. Depending on the type of shock, epinephrine can be used because of the inotropic effects to improve cardiac output, and with its vasopressor effects to increase systemic vascular resistance. That said, epinephrine is only a first-line choice in the treatment of anaphylactic shock. Epinephrine is also a first-line choice in many of the ACLS algorithms, such as cardiac arrest, and is also useful as adjunct to treatment of symptomatic bradycardia and asthma. Epinephrine can be given as an infusion, titrated to hemodynamic effect, with doses typically between 0.01 to 2 micrograms per kilogram per minute. In the case of cardiac arrest, however, it's given IV push, 1 milligram every 3 to 5 minutes for all pulseless rhythms. Significant adverse effects with this medication include tachycardia, dysrhythmias, ventricular fibrillation, pallor, and cool extremities. This effect is based for the tachycardia based on the beta-1 stimulation as well as the dysrhythmias and VFib, and the pallor and cool extremities would be related to the alpha-1 receptor stimulation. The next drug we'll talk about is dopamine. So dopamine is the only medication that stimulates all adrenergic receptors, including dopaminergic, which we reviewed in the autonomic nervous system and adrenergic receptor PowerPoint for the review. So it's an endogenous catecholamine, and again it stimulates dopaminergic, beta-1, alpha, beta-2, and alpha adrenergic receptors, and it will have variable dosing effects, therefore is typically titrated to the desired effect. We'll start with, there is some information with respect to dosing. So with low dose, which is around 1 to 5 micrograms per kilogram per minute, you get predominantly dopaminergic receptor stimulation, which causes actually vasodilatory effects in the mesenteric area, so increases perfusion to the vascular beds, increases renal blood flow, and can lead to an increase in urine output, although the effect on urine output will vary, and evidence in the clinical practice area remains somewhat controversial. It's important to recall with these dosing information with respect to dopamine that it's not absolute. Depending on the patient, you will sometimes see the sort of dopaminergic effects at a low dose between 1 to 5 mics, but you may not. You may see some beta effects, beta-1 effects as well. So it's very dependent on the patient, and therefore, again, we will titrate to effect. A moderate dose of dopamine tends to have beta-1 and beta-2 effects, resulting in an increase in heart rate and contractility, as well as vasodilation. This is often a desirable combination for the treatment of heart failure, as the increase in the contractility increases stroke volume and forward flow of the blood, and the vasodilation reduces the afterload, decreasing the workload of the heart. High doses stimulate both beta and alpha-1 receptors, adding a vasoconstrictor effect to the existing inotropic effect. This dose can be helpful in some shock states that require an increase in the afterload, so your SVR, such as septic shock or neurogenic shock. So again, depending on the dose and effect, dopamine can be used to improve renal blood flow for hypotension with concurrent bradycardia and to treat post-resuscitation and cardiogenic shock. Some of the side effects that you will see are, again, dose-dependent and include tachycardia, dysrhythmias, and hypertension. So that concludes this particular presentation. These materials are also discussed on your website, and if you have any further questions, please contact your instructor.